Samarth Life Sciences to our one more webinar conducted by Samarth Life Sciences. We are conducting today's webinar with very renowned Dr. Abhipsa ma'am, Dr. Abhipsa Mishra. She is a senior consultant, laparoscopic surgeon and infertility specialist in Utkal Hospital, Bhubaneswar. She's also been an ex-assistant professor at KIMS Hospital, Bhubaneswar. Talking about her awards and achievement, the list is so big. She has been a gold medalist from Maharashtra. She's also been awarded as a Dr. Late R. Anjelu Memorial Award. She has also been awarded Best Paper Award from Viva Foxy Shillong 2019. She also won Best Paper Award from the Ultimate Advances in Gynecology AIG 2015 Mumbai. She also won Best Paper Award from East Zone Yuva Foxy Bhubaneswar 2015, and she also received Best Paper Poster Award from Asha Bakshi Award in AICC RCOG Annual 2009. She also received Best Obstetric Paper in AICC RCOG New Zealand Conference, NZ Conference, New Delhi. She also won Best Paper Awards for Dr. R.H. Acharya Memorial Prize in Obstetrics at AOMOGS, Aurangabad, Maharashtra in 2009. She also received second prize at National Quiz at AICC-RCOG, New Delhi 2009. So as you can see, her award list is too big, and she has, in addition to that, she has also attended various conferences as a faculty. So we welcome Dr. Abhipsa Mishra today, and also we are very thankful for conducting this webinar today with us and being the speaker for our today's webinar. Thank you so much, ma'am, and we would like to welcome you on behalf of Samarth Life Sciences, and I would request you to start the webinar, ma'am. Thank you so much. Over to you, ma'am.
Yeah, thank you, Shweta, for your nice introduction. Let me share my screen first. Is it visible now?
Yes, ma'am, it is visible.
Okay. So very good evening to all of you. Today topic is medical management of endometriosis. As you know, endometriosis is an enigmatic disease which is a mystery for both the patient and the obstetrician and gynecologist. Okay. So what is endometriosis? Endometriosis is an inflammatory condition which is a chronic in nature, estrogen dependent disease, which is very, very painful condition, and it is always misdiagnosed, misunderstood and ineffectively treated. So early clinical diagnosis is the key to improve the care and quality of life. So it has been long since Thomas Cullen first described endometriosis, the full morphological and clinical picture of adenomyosis also. As you know, there are incidences 6 to 10% of reproductive age group are suffered from endometriosis. 1 in 10 women are affected by endometriosis. In India, at least 26 million people are suffering from endometriosis. Globally, we have March month as the endometriosis month, where approximately 176 to 190 million of people are suffering from endometriosis. Well, it is associated with 20 to 50% with infertility and 30 to 80% in pelvic pain. The problem is here the diagnosis is often delayed from 8 to 12 years of age from the initial onset of symptoms. So what is the key to diagnosis? The key to diagnosis is high degree of suspicion. The diagnosis of endometriosis is based upon history, symptom and sign, as there is a poor correlation between the staging and the pelvic pain. Early diagnosis is not possible with imaging modality like ultrasonography or MRI, though it helpful in moderate to severe disease. Laparoscopy is the gold standard in diagnosis and management. Absence of clinical evidence during examination does not rule out the disease, and the main part is the negative biopsy does not even rule out endometriosis. So according to ISHRE, empirical treatment in suspected case of endometriosis with oral contraceptive pill or NSAID or other hormonal treatment is very much needed. So before going to the treatment modality, let's see what is the pathogenesis. The main and most common theory which we always know from the history is retrograde menstruation, except that coelomic metaplasia, lymphatic and hematogenous spread, genetic predisposition, environmental exposure to certain agent is very, very important. The main theory which has come up is the endometriotic cell, which has the capacity to ability to sorry ability to proliferate, ability to apoptosis, greater potential and greater area of proliferation, and higher potential to neovascularization. So new drugs which has come up is targeting this theory. So what are the main three pillars of treatment? The main three pillars is medical management, number one. Second is surgical management. Third is in vitro fertilization, which is for infertility patient. Medical management alleviates the symptoms, reduce the size of the lesion and prevent the recurrence. But the demerits that it has all the drugs has its own side effect. Recurrence occurred after discontinuation and there is no effect on prevention of adhesion formation, and the endometrioma, if it is size is very big, it has no role. So here comes the roles of surgical management. Those who are unresponsive to medical treatment, those who are planning for pregnancy, and in those patients who have already completed their family and in the older age group. But to market that avoid repeated surgical procedure is important. So how we go for the medical management? Medical management is according to the patient's symptom, which is mainly pain, the preferences and priorities rather than staging of the disease. As I have already told, the disease stage does not correlate with the symptoms. So location wise, age wise, parity, whether she is planning for pregnancy, and according to the cost, availability and side effect of the medication, we choose the medication. So before going to proper what are the drugs, let's see what are the pathway of pain in this endometriosis. So all these are estrogen mediated neuromodulation of the peripheral sensory neuron, which is due to endometriotic cell. In the peripheral organ, there is an increased neuroangiogenesis, increase in the endovascular growth factor, autonomic nerve fiber dysregulation, neuroinflammation and peripheral sensitization, leading to increase in the interleukin cytokines like interleukin 1, interleukin 6, tumor necrotizing factor, prostaglandins. All these increase in peripheral organ cross-sensitize the microglial inflammation, which alter the brain structure, alter the brain function, alter the brain neurochemistry. And also it has a psychological distress and cognitive process. Coming to infertility. Infertility in endometriosis, there are a lot many reasons for infertility. Foremost is the inflammatory reaction, which is leading to impaired decidualization of the embryo attachment, DNA damage to the oocyte or sperm or endometrial cell. There is a impaired folliculogenesis, maturation and fertilization. As there is increase in the level of estrogen, there is a change in the tubal anatomy. There is a severe dense adhesion between the ovary, the tube, and of course it decreases the ovarian reserve, which is decreases the AMH. So what are the indication of medical management? It offered to relieve the pain, mainly dysmenorrhea, dyspareunia, chronic pelvic pain, non-cyclical pain related to either mild, moderate or severe endometriosis. Temporary relief of pain awaiting patients for IVF. Moderate to severe endometriosis who have already undergone surgical therapy for adjuvant therapy. Recurrence after surgical treatment in case of moderate to severe disease, patients who need a long-term management, and those especially who refuse surgery. Market, it is ineffective for infertility related problems, so it should not be offered to infertility patients. It is not recommended to prescribe pre-operative hormonal treatment to improve immediate outcome of the surgery, especially for the pain. So these are the classification of drugs: analgesic anti-inflammatory, which is NSAIDs, suppression of ovulation or estrogen, which is a contraceptive pill, danazol, gestinon, GnRH agonist plus airbag therapy. Direct action of endometriotic deposit is due to levonorgestrone IUD, progesterone antagonist, selective progesterone receptor modulator, estrogen receptor ligand, and newer drugs which are angiogenesis inhibitor and statins. And immunomodulators are inflammatory modules. So 3-star, which I have given, those who are in phase 1, 2, 3 trial, which has not yet come up to the market. So coming to the analgesic, it is the most commonly used first line agent, though there is the inconclusive evidence regarding its effectiveness in controlling endometriosis related pain. Still, we first and foremost prescribe these drugs to young girls who do not fit for hormonal therapy or surgery. So there are two varieties. One is selective, the other is non-selective. The major thing is the main part is the COX-2 receptor are more found in endometriotic cell. So COX-2 receptor inhibitor are more effective, though the cost is little higher. So it has been clearly proved that no NSAID has been proved more effective than other. It should be taken at least 1 to 2 days before the anticipated onset of menses, and if it's scheduled for 2 to 3 doses, it can be given with explaining the side effect of gastritis. So these are the common drugs which out of this we usually prescribe mefenamic acid, naproxen, ibuprofen. These three are non-selective COX-2 inhibitor, and selective COX-2 inhibitor are rofecoxib, celecoxib, parecoxib, and etorecoxib. Though it has a high cost and it is not proved that it is more effective. So the first line of treatment is non-NSAIDs or oral contraceptive pill oblique progesterone or combination of both for 3 to 6 months. If it fails, go for a second line therapy, which is a GnRH agonist and airbag therapy. And if it still fails, go for a laparoscopy method of ablation or excision of the endometriotic lesion. Coming to the hormonal treatment, the first line are progesterone. It can be pills, it can be IUD, or it can be subdural implant, which is the level A evidence of first line treatment. The antiprogesterone are gestanon, which is not commonly used. The second line is hormonal contraceptive, which is level B evidence of making it in a pseudo pregnancy state. The third line are GnRH agonists, which causes pseudomenopausal state. So according to the choice on the basis of patient's preference, side effect, efficacy, and cost and availability, usually we use it. Now coming to the combined hormonal contraceptives. So there are two methods which can be used either cyclical or continuously, but better clinical result has seen with the continuous rather than cyclical administration. There is no difference between the existing formulation in pain relief potency. Of course, the lower dose, which is 20 microgram, has a lower risk of venous thrombosis and currently is the treatment of choice. In these oral contraceptive pill, along with the third generation of progesterone and fourth generation progesterone combination is best. The other are use of vaginal contraceptive ring or transdermal patches are also recommended, though the evidence is level C. The advantage that these are cost effective, ease for administration, tolerability, and the best part it has protection against epithelial ovarian carcinoma, which is more common associated with endometriosis. But the limiting factors are long-term administration is needed. There is a risk of thromboembolism, high rate of recurrence and discontinuation after recurrence, and impaired fertility. Coming to the progesterone containing medication, oral medication now are there, which are cyproterone acetate and 5 milligram per day. Newer generation, 4th generation progesterone, which is Dienogest, most commonly nowadays we prescribe that 2 milligram per day. The other is dihydrogesterone, 20 milligram per day, and previously used to use norepinephrine assisted 2.5 to 5 milligram per day, but long-term use is needed. In injectable form, medroxyprogesterone assisted either 150 milligram intramuscularly every 3 monthly or 104 milligram subcutaneously every 3 monthly. The other antiprogesterone, though it has androgenic effect is more, usually the use is less. But the side effect of all these progesterone are breakthrough bleeding, reversible bone loss can occur. There is a high chance of thrombosis, androgenic effect like depression, decrease in the libido, hot flashes, and vaginal dryness. Though the breakthrough bleeding can be managed with a short time low dose estrogen administration. Now I will emphasize on the role of Dienogest, which is the orally active synthetic 4th generation progestin, highly selective for progesterone receptor. It inhibits the prostaglandin 2 and aromatase, which lead to anti-proliferative, angiogenesis, and anti-inflammatory action and low androgenic activity. It has neutral effect on the cardiovascular and metabolic system. Well, the dose is 2 milligram per day orally without a break. It can be started from any day of menstrual cycle. In the event of missed tablet, one should take immediately the other tablet, and as usual, rest of the tablet can be taken as. The contraindications are when the age is less than 18 years and the age is more than 65 years and the patient is lactating. Most frequently reported undesirable effect are headache, breast discomfort, and depressed mood, though it can be tackled very easily. Well, these are the studies which shows that estrogen and dinogestrone used for 3 months they have significant in reducing the endometriosis associated pelvic pain. It has equivalent efficacy to leupride, which has been used for 24 weeks. And the best part is nowadays, the long-term efficacy, like up to 5 years, it can be used without break. And also, this 5-year treatment help avoid the pain recurrence post-surgery. Well, also the best part is here the Dynagest also decrease the size of endometrioma approximately 75% without any significant change in the antral follicular count. The other thing which is come up as a role of dinogestrone in adenomyosis. Well, adenomyosis is a disease which is if the age is more than like 40 or 45, usually go for complete removal of the uterus. But suppose the patient is very young with adenomyosis and the size of uterus is less than 12 weeks, we go for a medical management. Here comes the role of Dinojet. It has been seen that evaluation and efficacy and safety of Dinojet in the treatment of painful symptom in patient with adenomyosis. Many randomized double trial control study has been done where 2 milligram per day for 16 weeks. The other studies has 2 weeks. That is symptomatic relief is very good. Okay. So what about the extragenitalia endometriosis, where the best treatment is surgical excision of those lesions, but those patients who are not fit for surgery or they are not willing for surgery, we can give a trial of Dynagest 2 milligram per day for 3 to 6 months. Suppose it failed, then we can go for a surgical management. Then coming to the other form of progesterone, that is levonorgestrone containing intrauterine system, which release 20 microgram of levonorgestrone per day over a period of 5 years. Those patients who have already completed their family, who do not desire to conceive, this is the best treatment modality as per me in those patients with a severe endometriosis, like those who have adenomyosis or ectovaginal endometriosis. And it has similar efficacy as GnRH analog with a role of pain management. Coming to the etonogestrel implant, which is a subcutaneous implant, Implanon or Nexplanon, which is effective for 3 years, but it is the insertion is little painful, and but it has an alternate option for those who do not desire fertility. Coming to the selective progesterone receptor modulator, which has now come up, is a mifepristone, which is used in abortion along with the misoprostol abortion pills. These mifepristone, the rule has come that 50 milligram per day for 6 months. Studies has shows that it has a good effect on the pelvic pain. But this dose it can be used as 2.5 to 5 or 10 milligram. And important thing is 5 milligram dose has significantly relieved adenomyosis related dysmenorrhea, which is a recent study in China has come up in 2020. And then coming to the aromatase inhibitor. Aromatase inhibitor is aromatase activity are overexpressed in endometriosis and conversion of testosterone to estrogen. So unlike GnRH agonist, aromatase inhibitor block estrogen synthesis both in the peripheral systems also. So anastrozole, letrozole, or exemestane are the third generation aromatase inhibitor that can be used as a 2.5 milligram of letrozole orally for 3 months with the ADVEC therapy. So ADVEC therapy is given in those patients with a rectovaginal endometriosis. So letrozole plus progesterone or oral contraceptive pill or GnRH agonist can be used. They are reversible, more potent, and have a faster onset of action. Though the side effects are mild, And combination with GnRH agonist and birth control pin can prevent follicular cyst formation, or progesterone can be added to decrease the bone loss. Now coming to the GnRH releasing hormone agonist, which is the second line drug therapy, which can be used in the injectable form or nasal spray form. A maximum use can be used up to 6 months, though the long term, like up to 12 months, we have used, but we have to use the add-back therapy to prevent the symptomatic, prevent a bone loss, that ethinyl estradiol or progesterone can be added, or a combination of estrogen plus progesterone can be added. So most common drugs is leuprolide 3.75 milligram. Either it can be used monthly or 12.25 milligram used 3 monthly. Goserelin Joladex can be used 3.6 milligram subcut monthly, and nasal spray are available in a BD dose that can be used. And now it has come up, this gonadotropin releasing hormone antagonist has come up, though it is not available in India, but it is FDA approved in US. Compared to GnRH agonist, lower degree of hypoestrogenism is seen and better side effect profile. That has come up with Orilisa trade name, 150 milligram once daily up to 24 months, or 200 milligram twice daily for up to 6 to 24 month maximum can be used, but the cost is little in a higher side. Danazol nowadays we are not using, as it is androgenic property, 400 to 800 milligram per day for 6 months, but as due to the higher side effect, we are not using danazol nowadays. But there's a study come up in 2000, which is an alternative route of danazol, like vaginal ring or intrauterine device, which is currently in search on studies, has shown improvement in the pain and better tolerability. So limitation of all these current therapy has the side effects. So we have to judge according to the patient profile which one we should use. So in general term, like those patients who are infertile, who are going for infertility treatment, ovarian suppression treatment should not be given to infertility treatment, and post-operative hormonal suppression should not be given with purpose for future pregnancy, increase the future pregnancy rate. In infertile women, should not be prescribed pentoxifylline or any other anti-inflammatory drug or letrozole outside the ovulation induction to improve the natural pregnancy. Well, operative laparoscopy is indicated in stage 3 or stage 4 compared to the good management of increase in the spontaneous pregnancy rate. Coming to the ART. In ART, the medical management of GnRH agonist prior to ART treatment to improve the live pregnancy rate is not recommended, and there is insufficient evidence to recommend prolonged administration of COC or progesterone as a pre-treatment to ART to increase the live rate. Well, is there any drugs which can, yes, primary prevention is not possible, but then secondary prevention of endometriosis, yes, of course, there is a role of combined oral contraceptive pills, post-operative IUD insertion. All these can be used after surgery for at least 18 to 24 months to decrease the recurrence rate. Coming to the adolescent group, which are most commonly affected with endometriosis, the best treatment is a combination of NSAID and oral contraceptive pill or progesterone therapy. Market GnRH agonists are used only in those girls which are beyond 16 years of age. And most important thing, those who have a progressive dysmenorrhea, that are not really with all these oral contraceptive pill or NSAID, diagnostic laparoscopy has to be done to confirm the diagnosis. Coming to the menopause, does menopause, in menopause question also they suffer from endometriosis? Of course, here comes the role of aromatase inhibitor, where the surgery is not feasible, and you should avoid estrogen only regimen for vasomotor symptom, those patients who have a risk of endometriosis, and continue the treatment of continue with the treatment of estrogen or progesterone or tibolone at least up to surgical after the surgery. You should go for a continuous treatment for natural menopause. So all these are all conventional therapy which we have already discussed. Now coming to newer therapy. Why there are nowadays so many researches going on for the newer therapy? Well, of course, this endometriosis require a long-term duration of therapy. Currently available treatment are limited by long-term use, prolonged hypoestrogenism and high rate of recurrence after the discontinuation of the therapy, and all these drugs are often interfere with infertility. That's why the search continue. So the newer drugs are anti-angiogenic factors, which are on all these research are mainly going on animal models. More and more human study are needed. But one thing which has come up is cabergoline or quinagoline, which is can be used zero point 0.5 milligram weekly twice for 3 months, which has reduced the endometriosis associated pelvic pain and also decreased the size of the endometrioma. The others, the others drugs which are on research are endostatin and Next. Statins, atorvastatins, simvastatin, all these have an anti-inflammatory and angiogenic and antioxidant property. That's why they are also under study, but the human studies are awaited. Coming to the TNF alpha blockers, which is come up with the infliximab and etanercept. These are also under study, and it also has seen that the size and number of endometriotic spots has decreased after its use, though there is a paucity of evidence in humans. The other one is peroxisomal proliferative activated receptors, that is rosiglitazone and pioglitazone. And human studies are underway, but here there is a possible risk of myocardial infarction and cardiovascular side effect. Pentoxifylline again is a TNF alpha blocking property, and it is also under studies. Coming to the alternate therapy, nowadays we advise for diet control, there is exercise, acupuncture, Chinese herbal medications. Mishra has specifically mentioned that it does not recommend the use of nutritional support or complementary or alternate medication, behavioral therapy or reflexology, but of course the Good Clinical Practice Foxy 2018 has mentioned that the evidence levels of use of all this therapy. So coming to the conclusion, in carefully selected women, medication can be either used alone or in combination with surgery. Currently, there is no evidence that the medical therapy improve any type of fertility. With more understanding of the pathophysiology, newer target therapy being developed with the hope of avoiding unwanted side effects and specifically targeting the lesion without affecting the ovarian function. Thank you. I want to conclude that the pain can change you, but never let you defeat you. So let's fight against this endometriosis. We should spread more and more awareness regarding this disease. And I would like to thank Samartha Life Science for giving me this opportunity to speak on it. I hope I have given justice to the topic, but of course, this is a vast topic, so coverage of all the points is not possible. But still, I thank you, all of you. Thank you for patience.
Thank you so much, ma'am. And it was an excellent presentation, I must say. And the topic which you have chosen is again, it is a very booming topic. Currently, the market for endometriosis is also increasing. It is actually an untouched topic, not being talked about much. So the topic which you have chosen is excellent. And now I think the presentation was very elaborative and very informative. So I'm sure it must have been very beneficial for all our attendees and participants. So I just request all our attendees, in case you have any questions, please put in the chat box, or you can put in the question and answer section, and we will take it up. So we can wait for 2-3 minutes, ma'am, in case anybody is having any questions.
Sure.
As you have rightly said that the topic endometriosis is a very vast topic and everything cannot be covered definitely in just a one presentation. So we request you also to get involved with us for upcoming webinars also, ma'am. We will be really happy to welcome you, that you will be conducting a more webinar with us in future, ma'am.
Thank you. Thank you.
Thank you so much, ma'am. And I think there has been no questions from our attendees. So on behalf of Samarth Life Sciences, I thanks all our participants for coming today and joining us the very informative webinar conducted by Dr. Abhipsa Mishra today. And also on behalf of entire team of Summer Life Sciences and all our participants, I thank you, ma'am, for conducting this webinar. Very